Hello, I'm Dr. Jenny Andrus, and welcome to Joint Ventures. In this OSC original podcast, we will discuss the latest medical news, diving deep into the science, the controversies, and of course, the applications to musculoskeletal medicine. Medical news, when it's presented in the lay media, is oftentimes sensational and even contradictory. When it comes to weight loss, everyone has an opinion, right? 5 small meals a day, intermittent fasting, maybe you just need a medicine or a different exercise trend. It's all confusing. Our goal here is to critically evaluate the latest medical news in a non-biased way and present it in a format that makes it easy to understand. Patients will ask me what I think about a recent medical headline, and in the office setting, we do not have the time to really get into the details. This forum is a great way for us to go through these topics in more detail, and I'm really hopeful that it helps you to make better decisions about your health. Now, before we get into today's topic, let me give you a little background on me. I'm an interventional pain management physician at Orthopedic and Spine Center in Newport News, Virginia. I'm a medical doctor who treats painful musculoskeletal conditions. Many of these conditions are treated with minimally invasive procedures, oftentimes for the spine, which I also perform. I also do non-operative care for chronic orthopedic conditions. So basically, I'm the doctor you're going to come see when your spine or your joints are bothering you, but you don't need or are not having surgery. I've been at OSC for over 15 years. Yes, getting old, I know. And I can tell you the topic of obesity has been a long-standing serious problem. So with that said, let's have a fun discussion about obesity. Said no one, right? I know. Everyone tunes out when the doctor says to lose weight. Me included. I am completely guilty of turning my head and ignoring the scale at the doctor's office too. But honestly, if you're overweight and your doctor isn't talking to you about weight loss, he or she is doing you an absolute disservice. Now, I personally hate sensational language, medically speaking sensational language, and I cringe when everything is called an epidemic. But honestly, guys, obesity in the U.S. is a horrible epidemic, and it's causing so much morbidity and mortality, which is doctor speak for illness and death. Obesity is the number one modifiable risk factor that I see every day in my patients for poor outcomes. Losing weight is the single thing that helps almost all of my patients have less pain, and I have many patients who have been able to stop coming to the doctor after losing weight. That is absolutely critical. Many of my patients over the years who have been coming to me for over a decade and who have serious orthopedic problems, they got so much relief from weight loss that they didn't need to see me or see me much less frequently when they lost weight. So if your doctor's a good doctor, he or she is going to have to talk to you about weight, despite it being a decidedly unfun conversation. So now for years, the AMA and other medical societies have classified obesity as a disease. And this really has more to do with policy decisions than with the science of it all. Classifying obesity as a disease puts more money behind studying it, and it changes the policy decisions on treatment. But is it really a disease? Well, proponents of labeling obesity as a disease say that formally recognizing obesity as a standalone disease would provide stronger medical and clinical legitimacy to the condition, increase access to care, and reduce societal stigma. Opponents, conversely, would say that portraying obesity as a disease reduces attention to the role of individual responsibility, encouraging unhealthy behaviors, which may perpetuate the problem, right? Meaning people who feel like they have a condition they can't control are not likely to get better. Okay, so which is it? Well, let's look at this from both angles. To start, let's consider why obesity would be a disease. Now, I am not going to spend huge amounts of time, and not going to bore you, hopefully, on the details of what is and what isn't the scientific definition of disease. I think it's more important to look at it from a science but a practical standpoint. Does obesity in and of itself cause illness? Well, extra adipose or fat accumulates in primarily the liver and the skeletal muscle. That results in organ damage. Obesity functions as a chronic inflamed state, which causes organ damage. Obesity is not necessary for insulin resistance, but a clear majority of people with obesity are insulin resistant. That leads to very serious metabolic dysregulation, including diabetes and high lipids. Obesity results in serious cardiovascular problems, including heart attack, stroke, and peripheral arterial disease. Obesity is a risk factor for developing 13, count them, 13 types of cancer. There is a bidirectional correlation with mental health disorders, particularly depression. So that means that depressed people are more likely to get obese, and obese people are more likely to get depressed. Obesity has the potential to ravage the body, causing a multitude of horrible, chronic, and potentially disabling health conditions. And y'all, I'm saving the effects of the musculoskeletal system for last because, of course, that's the most important to me. So even if obesity doesn't meet the complete scientific definition of a disease, I can say it causes severe illness and it needs aggressive management. Proponents of obesity as a disease also point heavily to reducing societal stigma about obesity by classifying as a disease. They would point to making health policy that allow for more access to care, etc. And I get these points too. But honestly, trying to do mental gymnastics around what is and what isn't a disease so people don't get their feelings hurt is counterproductive. The physician's job here is to be honest and try to fix or manage the problem. All right. Now, the converse idea is that obesity does not meet the scientific definition of disease, but instead is a modifiable risk factor for a disease. So think smoking. We all know smoking is directly linked to multiple cancers, heart attacks, and COPD. But smoking isn't a disease, right? It's something that causes serious morbidity and mortality, though. Proponents of not labeling obesity as a disease point to the concept that once something is labeled, people lose a sense of control over it. So if I tell you have a disease, all right, let's pick something kind of esoteric, tuberculosis. You'll say to me, okay, doctor, what do you need to give me to help me? What medicine do I take? What treatment are you give me? You think, okay, I have a disease and the doctor needs to fix it. By that logic, if obesity is a disease that you can't control, you stop trying to do the healthy things you need to get better and you start looking to outside sources. That means you look to pills, you look to surgery, you lose a sense of self-actualization. Or maybe you just give up and you get worse because you believe you can't get better. Now, I absolutely see the rationale here too. Doctors don't cure obesity. Let me say that again. I know it's not popular. Doctors don't cure obesity. Medications and surgery don't cure obesity. Now, don't get me wrong. They are amazing tools. And when your doctor gives you these, they can, whether they be medicine or bariatric surgery, they help people to lose a lot of weight, but they're just that, tools. And if you don't use the tool correctly, it doesn't work. Now, depending on what statistics you're going to look at, 35% to 44% of Americans are obese. In my mind, when a third of people have something, is it a disease or is it just kind of a normal state of being? That seems to be more on the side of obesity as a risk factor and not a disease itself. Now, in my opinion, I think both of these ideas are probably overly simplistic. Something can be a disease and you can still get better from it. So saying obesity is a disease that is curable only with patients being active in the cure is completely reasonable and to me satisfies both arguments. Now, with so many treatments coming along for obesity, particularly with the semaglutides getting so much attention, we need to know who with obesity needs treatment and who doesn't. The idea being that everybody with obesity doesn't necessarily need to be treated with medicine or surgery. So in January, The Lancet, which is a typically trusted medical journal, released the results of their Diabetes and Endocrinology Commission to define clinical obesity. This commission recommended not using the BMI or body mass index alone to measure obesity. The BMI would just be for screening and not diagnosing, and they recommended more direct measurements of adiposity or fat. Now, these body fat measurements are not always readily available, so they also recommended using waist to hip ratio and waist to height ratio. The BMI can underestimate fat in elderly or frail people and overestimate it in a muscular athlete. That being said, when the BMI is over 40, it can be assumed that the person has severe obesity without any other measurements. Now, the news headlines about this article all talked a ton about the commission recommendation not to focus on the BMI. I don't know why they did that, because that's really a minimal part of the recommendation. The bigger take home was that they separated obesity into two categories. Preclinical obesity, defined as a state of excess fat with preserved function of other tissues and organs, but with increased risk for developing clinical obesity, diabetes, cardiovascular disease, cancer, and mental disorders. That sounds awful. And clinical obesity, which is a chronic systemic illness characterized by alteration in the function of tissue and organs. Now, some organ dysfunction or substantial limitations in activity is required to diagnose clinical obesity. In the preclinical, the treatment is focused on prevention, and in the clinical, it's targeted more on corrective measures. An important detail in this definition of clinical obesity is that they addressed activity limitations as diagnostic criteria. Obesity is the number one modifiable cause of osteoarthritis. Osteoarthritis, or wear or tear of your joints, particularly the weight-bearing joints like the knees, develops as a direct effect of increased body size. Weight-related metabolic and inflammatory factors cause tissue damage, which is compounded by weight, causing mechanical stress. Excess fat compresses load-bearing joints and creates an inflamed environment within the tissues and joints. Muscles get weakened from inactivity and fatty infiltration. This makes them no longer able to provide adequate stability to the joint. Obese people tend to have lower muscle strength, particularly in the quadriceps, which is the front of your thigh, and the lumbar spine, which is your low back. To compensate, they alter their gait, the way they walk, and they adopt different body movement patterns to move that excess weight. Joint misalignment may occur due to that increased body size, altered posture, and skeletal muscle weakness. As weight increases, there's a reduction in steps per day of about 50%. This further perpetuates weakness, which further worsens pain. That leads to a fear of motion, fear avoidance of activity, and further deterioration. All right, so once you get on that hamster wheel of joint pain, less movement, more weight gain, more joint pain, less movement, that wheel, it is hard to get off. Now, weight loss reduces load on knees by fourfold. Weight loss of 5% body weight improves pain, and by 10% results in moderate to large clinical improvement in joint pain. Now, we discussed on our last episode that medicines get to the market with less than 50% pain control. So weight loss in many, many cases is by far superior to any medicine for joint pain. So what do we take away from all this? Whatever label you want to give it, obesity is dangerous. Do not get it twisted. There is no healthy obese, okay? While a person may not have clinical evidence of organ damage from excess weight, the excess weight is a huge risk factor for developing severe disease, and specifically for severe and potentially disabling musculoskeletal disorders. Now, please understand me, this is not about aesthetics or any value judgments. Many of us, me included, gain weight because we are too busy with life. We have work, we have family obligations. We don't focus on healthful eating and activity. It's not about being lazy. It's just a basic reality, though, that extra weight isn't good for us. All right, now how to fix this problem on a population level is a bigger issue, probably above my pay grade. That includes problems with food sources being highly processed, cultural, societal norms, our relative inactivity of the modern world, genetics, medicines, health conditions, mental health. Those all play roles. But none of these things should keep us from talking about obesity, encouraging us to try to make the changes needed to protect our health. Very rarely is obesity not manageable. That's the important part. It's not going to be easy to fix, but it is doable. Thank you so very much for listening to all this. I hope you found it helpful and got something to take away from it. Please come back to our next episode, where we're going to explore the recent updates to bone density screening guidelines and how that impacts your bone health. Thank you again, wishing you good health, and we'll see you again soon.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.